establishes whether or not there is a causal relationship between the vaccine and the reported AE. Data are based on reports submitted by the vaccinees through the QR code given at the end of the vaccination, or clinic visits at the UP Health Service, the allergy clinic, or emergency room admissions. In the vaccine program, we have used the guidance provided by the Philippine Society of Allergy, Asthma, and Immunology, both for the first dose and the second dose of the vaccine. A total of 6,862 suspected adverse reaction reports were received, evaluated, and analyzed. To disaggregate, of the 6,800 reports, 6,100 were reported after receiving the AZ COVID-19 vaccine. The PGH vaccination program is intended for the frontline health workers. Thus, the 936 reports, or 70% from the female respondents, and the younger population may be associated with the data that our health system is primarily composed of females and young adults under the age of 45. An adverse event experienced after vaccination is considered serious when it resulted to any of the following. 10 serious AEs were reported. A diagnosis of anaphylaxis is made when acute onset of skin or mucosal symptoms occurred with respiratory, circulatory, or gastrointestinal symptoms, or when acute onset hypotension or bronchospasm or laryngeal edema occurred after exposure to a known or a highly likely allergen for that patient. Brighton collaboration uses combinations of symptoms to define levels of diagnostic certainty to identify cases with sufficient evidence to assess as anaphylaxis. Brighton Level 1 represents the highest level of diagnostic certainty that the reported case is indeed a case of anaphylaxis. Levels 2 and 3 represent successively lower levels of diagnostic certainty. 75% of the anaphylaxis cases to the COVID vaccines had onset within 30 minutes of vaccination. They all had a history of allergies, half of them with previous anaphylaxis cases. 3 out of the 4 cases occurred among women. 2 cases were classified as Brighton Level 1 because they presented with generalized flushing and dyspnea, and 1 case was identified as Brighton Level 2 because the patient presented with respiratory and circulatory symptoms. We had 2 cases of bronchial asthma exacerbation where dyspnea occurred 5 and 24 hours after receiving the vaccine. Both patients were admitted. Guillain-Barré syndrome is thought to result from an immune response to a preceding infection or vaccination that cross-reacts with peripheral nerve components because of molecular mimicry. The immune response can be directed towards the myelin or the axon of the peripheral nerve. We have a 29-year-old female who presented with paresthesia of both hands and feet 19 days after receiving the AZ vaccine. On physical examination, she had facial vertigo, patchy sensory loss, impaired position and vibration sense in the lower extremities. She received a 5-day course of intravenous immunoglobulin and was discharged with symptoms improved after 2 weeks. 1 patient had elevated BP and required admission. It's interesting to note that also in the non-serious ACs, we had 111 cases of increased BP, and roughly half of the patients were not previously diagnosed to be hypertensive. We have limited data on the reported death of a PGH vaccinee. He's not a health worker, but a staff member of the Bureau of Fire Protection. He died 17 days after COVID vaccination. On the morning of his demise, he complained of left arm numbness and was received arrested at the East Avenue Medical Center, where he also expired. We now proceed to the non-serious AEs. Injection site pain, headache, tiredness, muscle pain, fever, and chills were the AEs most frequently reported in the various COVID vaccines. So some limitations. So first, these AEs were gathered through passive surveillance based on spontaneous reports to the PGH AEFI team. Spontaneous reporting is subject to reporting biases, including underreporting, which may be the case for the FDA report. Here, notice that the reports of the adverse events is just less than 1%, comparing that to the 40% suspected adverse reaction reports in PGH. Note, however, that reporting efficiency for serious adverse events is considered to be high. And in both the FDA and the PGH reports, the serious AE rate is at 0.006%. A second potential source of bias arises from stimulated reporting related to increased public and healthcare provider awareness of potential safety concerns. So it is possible that the intense media attention around the beginning of the national COVID-19 vaccination and the heightened awareness of reports of adverse events have affected vaccine recipients and healthcare provider behavior, including elevated concern and anxiety and higher index of suspicion of adverse events. So what will be covered? The benefits of a COVID-19 vaccine far outweigh the known and potential risks of the vaccine. Most AEs are reactogenic and they resolve quickly, and the AEFI reports are important in monitoring the safety of the COVID vaccines. So finally, I'd like to acknowledge the PGH AEFI team and thank them for